Good evening, students. Welcome to Basics of Medical Oncology and Chemotherapy 1 month course. Today is the 10th day of our course. In previous classes, we have discussed about the basics of certain concepts, pharmacology of alkylating agents. We have discussed about leukemias. Okay. So in today's class, let us try to learn about lymphoma. Lymphoma. So before understanding about lymphomas, we will I would like to tell you few important points. See, in previous classes, we have already discussed that this is a bone marrow. In bone marrow, we have stem cells. The stem cells will produce myeloblast, myeloblast, and the stem cells also differentiate into lymphoblast, lymphoblast. The myeloblast will further mature into neutrophil, eosinophil, and basophil. These neutrophils, eosinophils, and basophils are matured cells. These will eject into the blood circulation, and they will show their particular whatever action is required. They will show their action. These are matured WBCs. And along with these, stem cells also produces platelets and RBC. Now, see, in previous classes we have already discussed that in certain cases, if myeloblast cells are having any mutation, they will not be matured into neutrophil, eosinophil, and basophils. So in that case, what happens? The immature myeloblast cells will start dividing rapidly in the bone marrow, and these myeloblasts will directly they will try to spill into the blood, and that condition is called leukemia, and particularly that condition is called myeloid leukemia. So in myeloid leukemia, already we have discussed, we have two types. One is acute myeloid leukemia and chronic myeloid leukemia. These two concepts we have already discussed in previous classes. Now let's come to the lymphoblast. Actually, lymphoblasts are the blast cells which is differentiated from the stem cells of bone marrow. This lymphoblast will differentiate again, they will mature into lymphocytes. And this lymphocytes, in these lymphocytes we have two types. One is T lymphocyte, one is B lymphocyte. T lymphocyte will show cell mediated immunity. B lymphocytes further matures into plasma cell, and this plasma cell will produce immunoglobulins, which are antibodies, immunoglobulins, IgG, IgM, and all. Okay. So if patient has plasma cell cancer, that condition is called multiple myeloma. Even this is also we have already discussed in our previous classes. Now you see, if patient has if patient is not maturing the lymphoblast into lymphocyte, what happens? The lymphoblast cells will, if any, for example, if any mutation occurs into this lymphoblast will not mature into lymphocytes. In that case, what happens? These lymphoblast cells will start dividing rapidly in the bone marrow, and these lymphoblast cells will spill into the blood, and it will cause again leukemia, and this leukemia is called lymphoid leukemia. And in lymphoid leukemia, we have two more types. One is acute lymphoid leukemia and chronic lymphoid leukemia. Even these two concepts also we have already discussed in our previous classes. So in leukemia, we have four types. In leukemia, we have four types. In that, acute myeloid leukemia, chronic myeloid leukemia, and so these are myeloid leukemias, which is originated from myeloblast. And remaining two leukemias are acute lymphoid leukemia and chronic lymphoid leukemia. These leukemias are obtained from a lymphoblast. Okay, so from lymphoblast cells, this acute lymphoid leukemia, chronic lymphoid leukemia. So in leukemia we have four types. These four different types of leukemias we have already discussed in previous classes. Now in today's class, let us try to learn about lymphoma. Lymphomas are the cancers which are mainly associated with the lymphocytes. Actually, lymphocytes. These lymphocytes, these lymphocytes will try to, actually, lymphocytes, when they are matured, they are present either in the blood circulation, or from blood circulation they will be spilled into the lymphatic vessels, and they are highly concentrated in the lymph nodes. Lymphocytes are concentrated in the lymph nodes. When they spill into the lymphocyte in the lymph nodes, sometimes what happens, in the lymphocytes mutation occurs, and this mutation will try to divide rapidly in the lymph node. The cancer or the neoplastic cells in the lymph node is called lymphoma or lymphoma. In lymphoma we have other types also. Sometimes these lymphocytes will go and they will accumulate in the liver also, they will accumulate in the spleen also. But particularly in lymphoma, actually lymphoma is the condition where the lymphocytes will go and accumulate in the lymph nodes, in the lymphatic system. That is lymphoma. And in lymphoma we have two types. One is Hodgkin's Hodgkin's lymphoma, and the second one is non-Hodgkin's lymphoma. So in our class, in today's class, we will try to discuss about this Hodgkin's and non-Hodgkin's lymphoma. I think you all are following me. This is very easy concept. Just try to understand. Now, to understand about Hodgkin's lymphoma, see Hodgkin's lymphoma, it is a cancer. It is a malignant. It is the malignancy of lymphocytes in the lymph nodes. In the lymph nodes, the malignancy of lymphocytes in the lymph nodes is called Hodgkin's lymphoma. And in simple terms, you can also tell it as it is the cancer of lymphatic system, because these lymphocytes are not only they are present in lymph nodes. From the lymph nodes they will travel from one lymph node to the other lymph node through the lymphatic vessels. Because of that, we can simply tell it is the cancer of lymphatic system. Okay, this is the best definition. This is simple definition I'm trying to make you understand. Okay, so Hodgkin's lymphoma is also called HL. It was first described by Thomas Hodgkin in 1832. Because of this scientist doctor's name, it is named as Hodgkin's lymphoma. Okay, I think you understood the definition. It is just the cancer of lymphatic system. Now, see, just this is just revision. This is a lymphatic system, same like cardiovascular system. In cardiovascular system, the blood vessels are originating from the heart to all parts of the body. The arteries will travel to the tissues, and in the tissues, the arteries will supply blood. And again, from the arteries, the veins will connect to these arteries, and again, they will come back and they will pour blood back into the heart. So, in cardiovascular system, this system is closed system. Okay, arteries will send blood to the tissues, and from the tissues, again, the veins will be attaching to the arteries. So, it is a closed system. Whereas in lymphatic system it is the open system. Sometimes the fluid from the cardiovascular system will spill out. So this spilled out fluid will be collected by lymphatic system, and this lymphatic system again it will send the fluid to the blood vessels. So lymphatic system is the supportive system for cardiovascular system. This you have to remember. And in lymphatic vessels, only lymph is fluid. Actually, it is a very pale fluid, lymphatic fluid we call it. So lymphatic fluid is not having any blood cells, but it is having lymphocytes which are concentrated in lymph nodes. So you can see the concentrations of lymph nodes. Lymph nodes are highly concentrated in these areas, and they are concentrated in these areas, and mainly in the neck region here. Anyways, about the lymphatic system and all, it is we don't have time to study all its anatomy and its locations. Just for making you understand, I'm trying to tell. See, so the fluid which is present in the extracellular fluid, or the fluid which is spilled from the cardiovascular system, that will be collected by the lymph vessels, and it will be sent to the lymph nodes, and from the lymph nodes again it is sent to the blood vessels, or from there it will be sent to the other parts of cardiovascular system. So this, and in the lymph nodes we have so many other cells like lymphocytes, and its anatomy and physiology is not necessary for us. Okay, anyways, the cancer in the nodes, if the lymphocytes, or these lymphocytes which is having malignancy, or the lymphocytes which are neoplastic in nature, or the lymphocytes which are having mutations, these lymphocytes are highly sticky in nature. That's why they will go and they will accumulate in the lymph nodes, and they will increase the size of lymph nodes. And with that, it causes lymph lymphangitis. Okay, it will increase the inflammation of the lymph nodes, or lymph node size increases. Okay, so these are some basic things we need to understand. Now, in Hodgkin's lymphoma, in in Hodgkin's lymphoma, if you see the age, mainly Hodgkin's lymphoma is seen in two types of ages. One is in the people who are between 10 to 15 years of age in young population, and in the other populations, mainly those who are greater than 50 years. So Hodgkin's lymphoma can be seen in young population between 10 to 15 or up to 30 years, and it can be seen in people who are above 50 years. So two age groups it can be seen. This is important point we have to remember. And if you see the risk factors, there is no clear known cause of Hodgkin's lymphoma. There is no clear cause. Most of them are idiopathic. They are idiopathic in nature. Most of them are seen idiopathic, but few cases, in few cases, Hodgkin's lymphoma is seen mainly in the patients who are having EB virus infection. Epstein-Barr virus. In initial classes, I explained Epstein-Barr virus is one infection which will cause cancer. So Most of the Hodgkin's lymphoma cases are associated with EB virus infection, and few cases are also having association with HIV infection. So people who are with HIV also they are having greater risk factor. Okay, and another risk factor is people with same family. I mean siblings. Siblings are also having high risk of getting lymphoma. If say if a mother is having two daughters or two sons or daughter and son, so if one person gets this disease, the risk of getting to the other patient is very high. So siblings is also another risk which in Hodgkin's lymphoma people will be getting. And one important point about Hodgkin's lymphoma, one very important characteristic feature is there. All the Hodgkin's lymphoma are mainly characterized by one very specific lymphocyte, which is called Reed Reed Stenberg cell. Reed Stenberg cell. Actually, this is a lymphocyte. This is a very special type of lymphocyte. By seeing this Reed Stenberg cell only, we will try to diagnose that patient is having Hodgkin's lymphoma. So this Reed Stenberg cell is a macro cell. Which macro? It is a very big lymphocyte. This is a big lymphocyte which is having two nucleus in its cytoplasm, and in this two nucleus, two nucleoli is also present. So this is a very special character of Reed-Steinberg cell. So this is the special character of Reed-Steinberg cell. Just you can just see it as this Reed-Steinberg cell is very similar to owl. Okay, owl eyes. Okay, so by seeing this, you can understand that patient is having Hodgkin's lymphoma. This is very important point. All PharmD graduates should try to remember. Okay, so just try to see this is the normal lymphocytes, and here patient with Reed-Steinberg cell. You can just try to see. And in Reed-Steinberg cells, we have different types. Based on these types only, we differentiate Hodgkin's lymphoma into different classification. Okay, in Hodgkin's lymphoma, we have so many types. So based on these Reed-Steinberg cells, they are categorized into different types. So in Reed-Steinberg cells, you can see this is a very classic Reed-Steinberg cell, and this is a mononuclear. Steinberg cells will also have a single nucleus, and single nucleoli. So they are called mononuclear variants. And sometimes the lymphocytes will have popcorn type appearance. These are called popcorn cells, and these popcorn type of cells are very commonly seen in particular one type of Hodgkin's lymphoma, which is non-classical Hodgkin's lymphoma. Non-classical. This all classification I'll try to tell you. So try to remember the popcorn type of lymphocytes. And again, we have pleomorphic Reed-Steinberg cells and lacunar Steinberg cells are also one type, and mummified cells are also another types of Reed-Steinberg cells. Just for understanding, I'm telling all this. It is not necessary to understand for PharmD graduates. Okay. Now let us try to understand the classification of Hodgkin's lymphoma. In the classification of Hodgkin's lymphoma, see we have mainly two types. One is classical Hodgkin's lymphoma and non-classical Hodgkin's lymphoma. This non-classical Hodgkin's lymphoma is also called as nodular lymphocyte predominant Hodgkin's lymphoma. Let me repeat: nodular lymphocyte predominant. Nodular lymphocytes are mainly present in this type of non-classical type. Okay, so it is called non nodular lymphocyte predominant Hodgkin's lymphoma. Okay, so this non-classical type of lymphoma is mainly characterized by popcorn cells. That you have to remember: popcorn Reed-Steinberg cells, RS cells. Simply it is called as RS cells. Popcorn type of RS cells are main characteristic feature of non-classical or nodular lymphocyte predominant Hodgkin's lymphoma. Okay, NLPHL. It is named in short. And these non-classical type of lymphomas are very common in men. They are very common in men. And here, in this, if particularly if you see the RS cells, Reed-Steinberg cells are not commonly seen. They are not commonly seen. Popcorn cells are seen, but these are infrequent. If RS cells are seen, they are available in popcorn cells only. But mostly in nodular lymphocyte predominant Hodgkin's lymphoma, Reed-Steinberg cells are not particularly seen. They are not common. But in classical type of Hodgkin's lymphoma, Reed-Steinberg cell is very common. This is another important point you have to remember. Okay. So in classical type of Hodgkin's lymphoma, again we have four types. One is nodular Hodgkin's lymphoma. The second one is mixed Hodgkin's lymphoma. The third one is lymphocytic rich Hodgkin's lymphoma, and the fourth one is lymphocyte depleted Hodgkin's lymphoma. So these are four types of classical type of Hodgkin's lymphoma, and in non-classical, you have to remember nodular lymphocyte predominant Hodgkin's lymphoma. Now, to understand about all these classes, just I will try to give you important points about each class of Hodgkin's lymphoma. See, in nodular Hodgkin's lymphoma, these are called nodular sclerosis also. So in nodular sclerosis Hodgkin's lymphoma, it is very common in UK, and it is present mainly in young adults, especially in females, and it has good prognosis when this patient is treated, because nodular sclerosis is mainly located in the nodules. It is not infiltrated into the lymphatic vessels. That's why it is very easy to kill the cancer which is present in localized nodular region. So nodular sclerosis has good prognosis. And mixed cellularity, this is another type. In this, it is the second most common. Okay, and this type of classic Hodgkin's lymphoma is most common in males, and lymphocytic depleted ones are they are having very poor prognosis. It is very common in HIV positive. Lymphocyte depleted, just try to remember, in HIV patients all the immune cells are destroyed by the virus. So just understand, lymphocytic depleted Hodgkin's lymphoma is mainly seen in HIV patients. And the fourth one is lymphocyte rich. This type is very rare. Okay, and even this is having very less prognosis. It is having very less prognosis. So this is the important point about all the classes. And another important thing I would like to tell you, we have two types, right? One is classical and one is non-classical. In non-classical, what we have? We have nodular lymphocyte predominant Hodgkin's lymphoma. Okay. So just to make you, the main difference between this classical and non-classical is, in classical type of Hodgkin's lymphoma, mainly they are differentiated with the presence of CD15 positive cells. Okay. Actually, in immunohistochemistry, we have certain stains. Okay, we have CD15 stains, CD30 stains. When the stains are added to the particular cells of lymphocytes, they will be either positive or negative. Stain is positive, then they are called CD15 positive. Like that. See, in classical type of Hodgkin's lymphoma, they are CD15 positive, they are CD30 positive, and here they are CD45 negative. They are CD45 negative. This is important immunohistochemistry you have to understand. Okay, based on that also they are differentiated into either classical or non-classical. And in nodular lymphocyte predominant Hodgkin's lymphoma, in non-classical one, these non-classical types of lymphomas are CD15 negative and CD30 negative, but they are CD45 positive. This is very important. This is exactly opposite with the both classical and non-classical. And along with this, the fourth one, CD20 stain is positive for non-classical type of Hodgkin's lymphoma. This is important difference you should try to remember. And this is all not necessary for the family graduate, just for understanding purpose, for competitive exam purpose, I'm telling all this. To understand in detail about the classical type of and non-classical type of Hodgkin's lymphoma, just see histologic features. If you see for nodular sclerosis, the first one of classical, okay, they have mainly lacunar cells are concentrated here. Okay, and for mixed cellularity, many different types of cells, all mixed cells of RS cells are seen. And in lymphocytic is mainly the reactive lymphocytes and rich stem cells are mainly seen here. And in lymphocyte depletion, already I told this is common in HIV patients. Okay, and lymphocyte predominance here, mostly B cells are seen, and very few. This is non-classical. In non-classical one, I told RS cells, reed Sternberg cells, are very commonly seen. If they are seen, only popcorn cells are seen. And along with this, if reed Sternberg cells are not seen, particularly B cells are dominant here. B cells are dominant. B cells and popcorn cells are particularly seen in lymphocyte predominant non-classical type of Hodgkin's lymphoma. These are important points we have to remember. Now let us try to understand about the clinical features. Okay, clinical features of Hodgkin's lymphoma. See, in Hodgkin's lymphoma, if a patient is having localized cancer, so patient will have pain in the lymph nodes, or patient may not be having pain, so they are mostly asymptomatic. Patient with localized lymphomas, patient will be having pain in the lymph nodes, or patient will be having asymptomatic. So two things can be seen. Okay, wherever lymph nodes are involved, mainly in the neck region they are involved. Neck region lymph nodes are highly involved in Hodgkin's disease, especially in Hodgkin's disease. And if you see in non-Hodgkin's disease, actually Hodgkin's disease are mainly localized, whereas non-Hodgkin's disease from the lymph nodes and from the lymphatic vessels they travel from from the lymph nodes to the other tissues. About the non-Hodgkin's lymphoma we'll discuss later. Okay. Now, particularly for Hodgkin's lymphoma, if you see for localized people, pain can be seen or pain cannot be seen. Mainly in the neck region, they are involved. Okay. And main clinical presentation here, what we can see is patient will have Paul Epstein fever. Paul Epstein fever, very very important symptom clinical presentation for Hodgkin's lymphoma. Paul Epstein fever is the fever which is periodic in nature. Periodic in nature. Fever comes for 2 to 3 weeks. Again for 2 to 3 weeks, fever will be stopped. No fever. Again for next 2 to 3 weeks, fever will come. So this is called periodic fever, which is also called as Paul Epstein fever. Very very important clinical presentation for Hodgkin's lymphoma. Okay, and yeah, along with this, if you see the other clinical presentations, in CNS, patient will have mainly cerebellar dysfunction. In CNS, cerebellar dysfunction is seen in Hodgkin's lymphoma. In the investigation, if you see, patient will have Reed-Sternberg cells. Reed-Sternberg cells, already I told, Reed-Sternberg cells are particularly seen. And in X-ray, if you see, it is clearly seen that patient is having Hodgkin's lymphoma. And here, biopsy should be always preferred, but not fine needle aspiration is never seen, because in fine needle aspiration, Hodgkin's lymphoma is not particularly seen. So these are few important clinical presentations. Always remember, Paul Epstein fever is important, and patient will have pain in the areas where, and sometimes patient will have lymphadenopathy and periodic fever and Reed-Sternberg cells. These are important clinical presentations you should remember. Now, now let us see the staging. This is very very important. In Hodgkin's lymphoma, we have 4 stages. In stages, first stage of Hodgkin's lymphoma is having the involvement of single node. Okay, single node is involved, and in stage 2, 2 nodes are involved, and in stage 3, more than 2 nodes are involved, but this involvement is seen in the both the sides of the diaphragm. So if you see, this is diaphragm. In both the sides of the diaphragm, nodal involvement is seen, and that is called stage 3. And stage 4 Hodgkin's lymphoma is, it is infiltrated to the different nodes. Okay, this is the complicated stage. So these are 4 stages, and in after stages we have sub stages. You can see first stage is single node involvement, second stage is 2 nodal involvement, third stage is involvement of both the sides of the diaphragm. Okay, both the sides of diaphragm, and fourth stage it is involved in extranodal sides. It is involved from the nodes to the other sides also. That is complicated in fourth stage. And see, some people with the nodal involvement, people will have no symptoms. If patient has nodal involvement with no symptoms, it is named as 1A or 2A or 3A or 4A. Involvement of the nodes with no symptoms is classified as A. Okay, if patient has 1A, that means you should remember patient has one nodal involvement and patient is having no symptoms. And B indicates patient with symptoms like fever, drenching sweats, and weight loss. Patient will have weight loss, sweating, drenching sweating can be seen at night, and patient will have fever. Anyways, we have discussed. So if it is 1B, then you should understand that patient is having one nodal involvement and B patient is having symptoms. And X is another classification. Bulky disease. Here, more than one third of width of mediastinum is involved here. Okay, this is X, and E means involvement of single extranodal site, and CS is clinical stage, and PS is pathological stage. All these are different stages in the Hodgkin's lymphoma. I think you all understood. Okay, so after stages, now let us try to understand the management, because management is very important for the clinical pharmacist. So far, whatever we have discussed, all the pathological conditions, clinical presentations, their types, and the pathology and all, that is not at all required for pharmacist. But from here, it is important. So we will focus in the management of Hodgkin's lymphoma. See, actually, before understanding the clinical strategies and management, first always remember that I'm sorry, Hodgkin's lymphoma is always curable. It is having curable. It is curable. Okay, so in Hodgkin's lymphoma, we have mainly 2 strategies. We have chemotherapy and we have radiation therapy. Radiation therapy. Radiation therapy alone can be given, but this radiation therapy alone is given in stage 1 type of patients. And radiation plus chemotherapy both are given in the advanced level cases that we'll discuss now. Okay, this is very important point you have to remember. And see, before starting the management, we have 2 main goals of treating Hodgkin's lymphoma. first goal, we should always try to decrease the progression of disease from stage 1 to stage 2. We should not never take the patient from stage 1 to stage 2. So we should try to decrease the progression and we should focus on cure of the disease. Number 1. And number 2, always try to remember that radiation therapy and chemotherapy has a lot of adverse effects. So always try to monitor adverse effects. Here, main goal in the Hodgkin's lymphoma is to decrease the risk of infertility. 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 Infertility is very important adverse effect with radiation therapy and in chemotherapy as well. So the two goals is to decrease the progression and improve the patient's condition by curing the patient. And second is to reduce adverse effects, mainly to decrease the risk of infertility. So these two goals is always we have to keep in mind while treating the patient. Okay. So now see, actually in treating the patients, we have three main stages of treating patients. Number 1, we have early stage disease. Early stage disease. Early stage disease is the patient. These early stage disease patients are very favorable for treating. They are called favorable patients. These early stage patients will have 90% of curability. They have 90% cure. Okay, and these early stage disease patients are those patients who are in stage 1 and in stage 1A. Stage 1 and stage 1A patients are considered as early stage disease patients or favorable patients whose prognosis is 90%. 90% of patients will be cured in this stage. Okay, and in this stage, single radiation therapy is enough. Single radiation therapy itself can cure the patient. And here in radiation therapy, actually we have IFRT. IFRT is involved field radiation therapy. This IFRT radiation therapy is mainly localized on the localized area. It is radiation is exposed only at the localized area, not to the total body. Okay, so IFRT is the drug of choice in patients who are at early stage or who are at favorable stage. But here one adverse effect we have, if radiation therapy is given alone in stage 1 and 1A, here patient is having risk of causing secondary cancers. Secondary cancers can be seen. Okay, that's why radiation therapy alone is not suggested in most of the Hodgkin's lymphoma. Okay, so because of that, always in stage 1 or in stage 1A or in stage 2, we have to go with radiation therapy plus chemotherapy, or alone chemotherapy also can be given. Here in combination therapy of early stage, here we have one strategy. Chemotherapy. In chemotherapy we have ABVD regimen. ABVD regimen. In previous class I already told you. A indicates adriamycin. Adriamycin is the other name for doxorubicin. Doxorubicin. And B indicates bleomycin. Bleomycin. Always remember these regimens. Bleomycin. And B indicates vinblastine. Vinblastine. In yesterday's class, we discussed everything about vinblastine. Vinblastine, okay? And D indicates dacarbazine. 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 Always remember, in management of stage 1 and 1A, these are favorable conditions or favorable stages. This is early stage disease. In early stage disease, we have alone radiation therapy, but radiation therapy is not suggested because it is having secondary cancer ability. That's why radiation therapy and chemotherapy is always given in combination. So here in combination we have ABVD regimen. Okay, ABVD regimen you have to remember. This is the treatment of stage 1A and stage 1. Okay, now let's talk about, before, this flowchart will come back. Okay, before understanding this flowchart, we will first understand what is early stage favorable stage, what is early stage unfavorable stage, what is advanced stage. Okay, this one already we have discussed. Early stage favorable stage is the condition where patient is having only 1A or 2A. Here we can say it as 2A also, 1A and 2A. Patient with 1A and 2A, they are considered as early stage favorable stage. Here we have single radiation therapy plus chemotherapy. In this we have ABVD regimen. ABVD regimen. We'll come back. We'll discuss later about this Hodgkin's lymphoma flowchart. First, now let us discuss about the early stage unfavorable condition or unfavorable disease. Early stage unfavorable disease condition. Here unfavorable disease condition is that condition which is having stage 1, stage 2, stage 1, stage 2, and here patient will have symptoms stage B. 1 and 2B are considered as unfavorable condition patients. So in these patients, The prognosis is very less if it is given alone radiation therapy. Alone radiation therapy is given, its prognosis is very less. That's why it is always given with radiation therapy and chemotherapy. In early stage unfavorable condition, we have one regimen which is ABVD regimen. In early stage favorable condition, we have ABVD, and in unfavorable condition also we have ABVD. Okay, ABVD condition, ABVD. So this is very similar with favorable and unfavorable condition. But one thing you have to remember, in favorable and unfavorable condition, the stage is patient is having symptoms. B means symptoms. In previous slide I already explained. Now the third stage is advanced stage. Advanced stage patients are those patients who are with stage 3 and 4. Okay, so in these cases, prognosis is very less, even with radiation and with chemotherapy. In both the cases, prognosis is very less. And here, along with radiation therapy, we have strategies. We have MOPP regimen. This is very, very important regimen. While explaining about alkylating agents, I explained. Okay, in MOPP regimen, the M indicates mechlorothamine, amine. This is the important, the first drug in alkylating agent I explained. Okay, mechlorothamine, and O indicates oncovin. Oncovin is the other name for vincristine. We discussed about vincristine everything in previous class. Okay, and P indicates procarbazine, and next P indicates prednisolone. Prednisolone. Always remember this regimen. About this regimen, we have already discussed in previous classes. But about vincristine, mechlorothamine pharmacology, we have already discussed their adverse effects and all. Procarbazine and prednisolone we'll discuss in upcoming lectures. We'll discuss. Okay, so for advanced level of Hodgkin's lymphoma, always we'll go with MOPP. And nowadays we have newer drugs also. Before understanding about newer drugs, now let us try to see the flow chart. This is very, very important. Just try to remember this flow chart. If patient is at favorable stage, early stage favorable stage, we will go with the radiation therapy plus chemotherapy. Alone radiation therapy is also sufficient here, but we'll go with chemotherapy also, because to reduce the patient's adverse effects. Like patient will have additional secondary cancers. Due to radiation therapy, cancers, again, secondary cancers can be seen. Okay. So here 2 to 4 cycles of combination chemotherapy is given. In combination chemotherapy, already we discussed, we have ABVD regimen. Okay. So that is given in favorable condition. And after the treatment, if patient has primary refractory or relapse in less than 1 year, we will go with salvage chemotherapy. Actually, in salvage chemotherapy is the therapy where patient will have high dose chemotherapy, and we will consider autograft, or here we have bone marrow transplantation or organ transplantation. That is called autograft, organ transplantation, or surgeries will be done here. Okay, if patient has relapsed in less than 1 year. So this is about early stage favorable Hodgkin's lymphoma. And here early stage unfavorable condition who are in stage 1A and stage 1B. Here we will go with the 4 cycles of combination chemotherapy and radiation therapy. Okay, here again we have ABVD regimen. And after giving this regimen, if relapse is in greater than 1 year, we will go with radiation therapy in localized area. Okay, or salvage chemotherapy plus stem cell support is given. And in advanced stage patients who are in stage 3 and 4, combination chemotherapy is given for 6 to 8 cycles. And the remaining concept is followed the same like stage 1A and stage 1B patients. Okay, so this is the uh, treatment strategies and flow chart for Hodgkin's lymphoma. I think this flow chart is important. Okay, try to remember. Now we have few newer drugs for Hodgkin's lymphoma. New drugs are always coming, and they will be studying in different patients. So in Hodgkin's lymphoma, rituximab is one drug. Rituximab is mainly given for nodular lymphocyte predominant Hodgkin's lymphoma. So this drug is very effective for NLPHL. And another new drug, panobinostat. This is another novel drug which is studied in Hodgkin's lymphoma, and it is used. Actually, about this panobinostat, 2 years ago, I published one paper review article about this panobinostat. I'll try to share that paper in our group. Okay, so panobinostat is a very important HDS inhibitor. Okay, and it is considered as orphan drug. So orphan drug is the drug which is used for rare disease conditions, and their manufacturing is very, very limitedly made. Okay, so orphan drugs are not commonly used, same like paracetamol and other drugs. Once the drug is manufactured, if it is not marketed, or if it is not used, what happens? The manufacturing companies will be lost. they will have to bear the financial crisis. So orphan drugs are those drugs which are manufactured by the companies, and in few cases, if these drugs are not marketed or not used, the manufacturing companies will not have financial crisis. In that cases, government will save the company. That's why orphan drugs are those drugs which are manufactured for rare disease conditions, and these drugs are used very rarely, they are not easily available. Okay, so those drugs are called orphan drugs. So panabinostat is granted with orphan drug designation. Orphan drugs are special drugs actually. And gemcitabine is another newer drug which is having activity in relapsed classic Hodgkin's lymphoma conditions. And bortezomib and lenalidomide licensed for myeloma, and it is being investigated for many other relapsed Hodgkin's lymphoma conditions. So these are different newer drugs which are used for Hodgkin's lymphoma. I think you all got brief uh, summary about Hodgkin's lymphoma. Hodgkin's lymphoma. Okay, in tomorrow's lecture, we'll go with non-Hodgkin's lymphoma. Till then, see you. Bye bye.